Hello, my name is Erin Allen, and I'm an athletic trainer. And my presentation is on eccentrics and its role in injury prevention for the football athlete. And I am going to focus on two separate injuries that were listed in the syllabus, one being quadricep and patellar tendinitis, and the other being adductor tendinopathy and groin pain. So, first presentation is going to be on kind of a combination of both quadriceps and patellar tendinopathy. Quadriceps and patellar tendinitis are a common chronic pathology of the knee that has a high prevalence in all athletes and even the general population. The quadriceps tendon, as we know, attaches the quadricep muscle to the superior aspect of the patella, and the patellar tendon is often considered the tendon attaching the inferior aspect of the patella to the tibia. Tendinopathy is characterized by microscopic tears and tissue degeneration due to excessive and repetitive mechanical loading of the patellar and quadriceps tendon. Previous literature indicates that tendon injuries account for possibly up to 50% of injuries sustained during athletics. Furthermore, more than about one-third of athletes presenting for treatment with patellar and quadriceps tendinopathy were unable to return to sport within 6 months, and more than half of the athletes that reported were forced to retire from their sport, indicating the vital need for a comprehensive intervention to allow the athletes to return to full athletic participation. First, tendinopathy can be acute and/or chronic in nature. Acute tendinopathy is often referred to as patellar or quadriceps tendinitis, which can be treated with a variety of treatment interventions such as modalities, whereas chronic tendinopathy is referred to as tendinosis, where the primary treatment intervention is exercise. Tendinitis is a state where the tendon tissue is involved in an inflammatory process, whereas tendinosis is a chronic degenerative tendon state that lacks the inflammatory process. Eccentric exercises are the gold standard for treating tendinopathy, along with heavy slow resistance training throughout the concentric phase of each exercise. So chronic tendinopathy of the patellar and quadriceps tendon are seen in approximately 22% of tendon overuse injuries in the athletic population. Athletes typically present with anterior knee pain that increases with patellar or quadriceps loading, such as squatting, running, and jumping. The most common location is the origin of the patellar tendon, accounting for about 65 to 70% of cases, followed by the insertion of the quadriceps tendon at the superior pole of the patella, which accounts for 20 to 25% of cases. Symptoms usually worsen over time and intensify when the patella is under load, but typically subsides at rest. There are several risk factors that contribute to the development of quadriceps and patellar tendinopathy that clinicians should assess and consider during the initial evaluation. These risk factors include lower extremity weakness, quadricep and hamstring flexibility, reduced ankle dorsiflexion, postural alignment, foot structure, training volume, and poor biomechanics, which can influence jumping performance and contribute to higher ground reaction forces. During the examination, it's important to assess quadricep and hamstring, gastroc, soleus, and even glute max and glute med strength, as weakness is typically present among these muscle groups, which contribute to the tendinopathy. Assessing flexibility can be completed with the Thomas test or an active straight leg raised assessment to assess quadricep and hamstring flexibility, respectively. Decreased ankle range of motion can contribute to increased ground reaction forces influencing quadricep and patellar tendinopathies, so it may be valuable to consider implementing a lunge assessment for a weight-bearing ankle dorsiflexion range of motion. Functional assessments can include performing a single leg decline squat, jumping, or step up or step down to assess for pain and movement patterns to address further during the recovery process. And typically, palpation of the inferior or superior pole of the patella will elicit pain in patellar and quadriceps tendinopathy, respectively. So phase 1 is focused on restoring range of motion deficits, controlling pain and inflammation, and if present, and inflammation will only be present in acute tendinitis, not tendinosis. So during this stage of the eccentric rehabilitation program, clinicians should focus on implementing a strengthening program to restore muscle strength and educate the athlete on their injury and importance of symptom monitoring management. During the initial stage, an athlete should reduce the load being placed on the damaged tendon, such as refraining from jumping and running initially, and participate in other training interventions that do not increase the load on the quadricep and patellar tendon, basically protecting the damaged tissue with relative rest. Another intervention to consider includes counterforce bracing or taping techniques, which have been shown to decrease patellar tendon pain with a single leg decline squat and during sports activity with a patellar strap, taping, or brace um, was applied compared to no taper bracing. Orthotics are another intervention to recommend or utilize as hyperpronation is a contributing factor to patellar tendon pain. Other treatment interventions are listed, such as neuromuscular re-education, electrical stimulation, lower extremity stretching, um, electrical stimulation for pain management, and cryotherapy. Um, Cryotherapy, cross-friction massage, or manual therapy encourages normal realignment of collagen fibers and is effective in combination with iontophoresis. Iontophoresis with dexamethasone and lidocaine was very effective for pain reduction and increasing function in athletes with patellar tendinopathy per previous research. And therapeutic ultrasound also has a positive effect on collagen production when used at the appropriate settings of 3 megahertz at 1.0 watts per centimeter squared. Previous research has shown that extracorporeal shockwave therapy is safe and promising treatment for patellar tendinopathy and is effective in reducing pain and increasing function. Also, leukocyte-rich, platelet-rich plasma injections, along with dry needling, provided earlier symptomatic relief compared to just dry needling and eccentric exercise. However, of all the treatment modalities available, eccentric exercise is by far the most effective treatment modality for treating quadriceps and patellar tendinopathy. So I've kind of broken down each week into their 7 days, with some recommended exercises during each day. Granted, these can all be changed or altered depending on how the athlete progresses, and any pain symptoms the athlete might have. Eccentric exercises are the gold standard conservative treatment modality for treating patellar and quadriceps tendon. So, loading the tendon in a controlled environment free from overuse with progressive stress and loading improves the tendon function. Therefore, we must implement therapeutic exercise interventions into our athletes' recovery. So, like I had mentioned, it's important to modify our load based on the athlete's reported symptoms of pain and eventually progress the load on the quadricep and patellar tendon as the pain reduces. So during the performance of eccentric exercise, some pain is acceptable, but the symptoms should subside once the exercise is completed. Previous literature has recommended a pain rating of 3 out of 10 or less on the numeric pain rating scale, but some clinicians allow the pain rating to go a little bit higher. Isometric exercises are indicated to reduce and manage tendon pain and initiate the muscle tendon loading as pain during isotonic exercises persist in the early stages of injury management. So isometrics are to be performed submaximally at 5 reps of 45 seconds with isometric holds 2 to 3 times per day in a mid-range quadricep exercise, such as knee extension machine from 30 to 60 degrees, a Spanish squat with an isometric hold between 45 and 90 degrees of knee flexion, as well as a basic isometric squat hold or a wall squat. Ideally, utilizing a knee extension machine to perform isometrics has been shown to effectively isolate the quadriceps. So if that's available, that is recommended. Throughout the initial phases of rehabilitation, resistance for isometric activity should be increased as quickly as tolerated and performed single leg when possible. A decline squat program is initiated after the initial acute stage of injury has subsided, as a decline squat program is superior to standard squat training for treating patellar and quadriceps tendinopathy. There is significantly greater patellar tendon loading and quadriceps activation with the decline squat, which is what we're looking for. And decline squats are performed 3 sets of 15 reps 2 times daily and recommended to continue for 12 weeks, even if the athlete has returned to full athletic participation. And then isotonic exercises are initiated when the athlete can perform the movement with minimal pain, often referred to as less than 3 out of 10 on the numeric pain scale. And heavy slow resistance can be implemented and has been proven to significantly improve function and reduce pain in athletes with patellar tendinopathy. So on day 1, I incorporated some additional accessory calf raises and soleus raises, just as some examples. This is a good time to address other strength and flexibility deficits while the athlete is performing relative rest from football and painful activities. Utilizing a stationary bike, aquatics, or pool running are effective ways of maintaining cardiovascular fitness without increasing the tendon load initially. I have also incorporated hip and core strengthening throughout the week, as well as hamstring strengthening, both concentric and eccentric, to address any muscle imbalances. Single link balance and proprioception are also indicated to incorporate into the rehabilitation program, which can consist of single leg football throwing to incorporate sport specific activities and keep the athlete engaged in the rehab, or utilize a BOSU ball to challenge proprioception. Football players must maintain their general strength, so incorporating accessory lifts, adjusting other areas of body can also be incorporated during the strength program, such as upper extremity lifts, gastroc soleus complex, hamstring strengthening, such as a single leg Romanian deadlift or deadlifting. So as you can kind of see, I started the first 3 days with submax isometrics, and on day 3, I initiated some eccentric squat training in with slow tempo, and then kind of incorporated that in every day the rest of the week, alternating between heavy slow resistance on day 4 and day 6, as it's initially performed 2 times a week, and then incorporating more submax isometrics on day 5 and day 7 with eccentrics. So week 2 is more of a progression of week 1, continuing to perform decline squats that, once symptoms of pain begin to subside, progress the athlete to performing a 25-degree decline eccentric squat, starting with bilateral and then progressing to just bilateral during the concentric phase, and then unilateral during the eccentric phase, and ultimately progressing from single leg decline squat to then with weighted resistance. Speeds can also be increased during the concentric and eccentric phases as the athlete progresses through their recovery. I have increased the eccentric strength volume during this week, as well as the athlete pain levels are more managed this week. I created an eccentric program for each day of the week, more as guidelines of recommended research with some ideas to choose from. The athlete would not have to perform all of the accessory exercises written in one day, but prior research does recommend performing decline squats 2 times daily at 3 sets of 15 reps. I've also incorporated additional eccentric strength training exercise, such as a step down that can be performed laterally initially and then progress to forward, and increasing heights will be progressed throughout the 6-week protocol. So as you can see, heavy slow resistance and submax isometrics kind of alternate every other day, with increasing speeds and tempos on the eccentric decline squats and drop squats, with accessory exercises and hip and core strengthening still implemented into the rehab program. So now we'd move on to phase 2. The goal of phase 2 is to progress strength, proprioception, and flexibility. The idea is to gradually increase the load of the quadricep muscle and patellar tendon while monitoring for symptoms of pain. As symptoms begin to subside, incorporating functional strengthening into the rehab program is indicated, as well as addressing faulty movement patterns during this stage. And during this stage, it's important to continue monitoring pain symptoms and utilize modalities as needed for pain management. So week 3 is again another progression of week 2. During this week, progressing the speed, intensity, and resistance within each exercise is recommended, focusing on progressing decline squats from double leg with increased speeds to single leg with progressive resistances. Progressing the distance of a step down is also indicated to increase the load of the patellar and quadriceps tendon. And again, in this week, I've incorporated accessory lifts and progressive hip and core strengthening, and some eccentric hamstring strengthening as well, and then implementing single leg balance just to improve stability. As you can see, by day 7, the decline squats are being progressively resisted and are now single leg with slow resistance, and the drop squats are being performed at a fast tempo. Now, week 4 continues to progress eccentric strengthening with progressive resistance, focusing on performing 3 sets of 15 twice daily still. During this week, implementing progressive lower extremity strengthening. Some examples would include a goblet squat, split squat, step up, single leg Romanian deadlift, deadlifts, and lunges, and progress the load and ultimately progress to a single leg squat are just a few examples to implement into the rehab program, focusing on proper movement biomechanics as we progress through this week, and making sure We are addressing any movement dysfunctions to sort of further prevent injury in the future. And so I've incorporated the progressive lower extremity strengthening every other day this week, along with the eccentrics and accessory lifts on the relative rest days. So now that we are on to phase 3, the goal of phase 3 is to continue to progress strength and flexibility while reintroducing energy storage loads to the quadricep muscle and patellar tendon, as this is crucial to increasing the load tolerance and enhance lower extremity power production as the athlete progresses through their return to sport program. The athlete must demonstrate good strength, which is objectively measured by the athlete's ability to perform 4 sets of 8 reps on a single leg press with approximately 150% of their body weight. And they must also demonstrate good load tolerance, which is defined as a minimum of 3 out of 10 pain on the numeric pain scale, while performing exercises. And the pain returns to baseline during functional load tests, such as a single leg decline squat 24 hours after completing the assessment. The initial starting point of phase 3 will depend solely on the individual, as each individual will recover and progress differently. However, the volume and intensities will be progressed as the athlete's tolerance increases and depending on the athlete's position in football. Again, utilizing modalities for pain management when needed through this stage as well. So week 5 is going to focus on progressing lower extremity strength and power. We'll begin initiating a running progression, which is recommended per the patient tolerance. Continuing with the decline squat progression is indicated with progressive resistance per the athlete's load tolerance. Focusing on proper landing mechanics is crucial, as improper landing mechanics are a significant risk factor for developing patellar and quadriceps tendinopathy. So beginning drop jumps are indicated once the athlete is pain-free, performing an 8-inch step down. So as you can see, I've progressed the step down to an 8-inch step, and then towards the later half of the week, incorporated some double leg drop jumps, just a few reps here and there with some skipping and jump roping, and then progressing the loads as the week continues. Progressive resistance and speed is recommended to progress the tendon load tolerance and restoring power. And so also incorporating more functional strengthening is recommended in this stage, as you can see, and just basically progressing the resistance on the functional strengthening. So now the final week focuses more on sport-specific and even position-specific activities for the football athlete. I organized the week into an agility, strengthening, and plyometric focused sessions. The athlete will have a relative rest day. I did not provide the athlete with a complete rest day, as frequently in my experience and highlighted by previous research, some athletes actually experience an increase in symptoms on the day after a complete rest day. So a program that loads the tendon daily is ideal. So incorporating submaximal isometrics on relative rest days are more advantageous. The first day of the week includes agility drills focused on changing direction, acceleration, and deceleration drills, cutting and other sport-specific movements to reintroduce the sport-specific demands and focus on proper movement patterns as well. The second day is a comprehensive progressive strengthening day, where I've included some ideas of functional strength training exercises and continuing with our eccentric strengthening decline squat program throughout the week with supplementary eccentric strengthening exercises. And then incorporating a progressive plyometric drill on the third day to restore the athlete's power development and progress load tolerance on the quadricep and patellar tendon are indicated prior to returning the athlete to their full athletic participation. And then later on in the week, I've incorporated position-specific drills. It's essential, particularly in football, as a kicker will have different sport-specific demands compared to an offensive lineman and maybe a corner. So with return to competition considerations, there's actually some conflicting recommendations regarding return to sport during a rehab intervention. However, in a professional sports setting, the athletes are being held from their occupation, so a quick return to sport is ideal. It is recommended that the athlete has less than a 3 out of 10 pain on the visual analog scale with activity before returning to full athletic participation as a subjective measure. Objectively, the athlete can return to sport once full training is tolerated without activity modifications, limitations, or symptom provocation, and all power deficits have been resolved. We can utilize functional hop testing, such as the triple hop test for distance or maximal vertical jump assessment are some recommendations for assessing power deficits, or even an isokinetic test could provide valuable objective results if available. Once the athlete has returned to sport, it's important they continue to participate in an eccentric strengthening exercise program, even after the symptoms have subsided. Previous research recommends performing an eccentric decline squat program at a dosage of 3 sets of 15 repetitions twice daily for 12 weeks, even if the athletes return to their athletic participation. Previous literature also recommends maintaining a strengthening program, such as loaded split squats, leg press, or seated knee extension, with intermittent isometric exercises performed either before or after training. Athletes must also continue with their flexibility and stretching protocol, as well as addressing strength deficits with gluteal and calf strengthening exercises incorporated into their strength and conditioning programs. So that concludes my patellar and quadricep tendinopathy presentation. Here's a list of some of my references, and these are the other half of my references. And then kind of switching gears here, we are going to discuss adductor tendinopathy and groin pain and an eccentric driven rehab protocol to go with that in the football athlete. Adductor related groin injuries are the most common injury to the hip and groin region, which contributes to about 63% of all injuries that occur in the hip and groin region. It is estimated that injuries to the hip and pelvis region account for about 2 to 5% of all sport-related injuries and up to 11% of all running-related injuries. In sports that require sudden change of directions, constant acceleration and deceleration, tackling and kicking, just like in football, their chronic and recurrent groin pain is frequently displayed, which can be from the presence of adductor tendinopathy. Groin overuse injuries that are frequently presented in the multidirectional sports like football are more often involved in tendons and their insertions. Groin injuries often present with multiple problems, such as a high rate of reoccurrence with prolonged durations of inactivity, sometimes an unclear prognosis, and long-term symptoms. It is also important to note that most adductor strains are incomplete tears close to the musculotendinous junction and are often responsible for evolving into chronic tendinopathy. Therefore, it's important to perform a comprehensive examination also because groin pain can be a referred symptom for various conditions and injuries to implement an effective treatment strategy. So the following will be an overview regarding the evaluation of adductor tendinopathy and groin pain, followed by an eccentrically driven rehab program with exercise recommendations compiled from previous literature. So insertional tendinopathy of the adductors presents with groin pain that may radiate to the medial aspect of the thigh. Chronic groin pain is typically caused by adductor tendinopathy. Injuries to the groin typically occur in males and participate in sports that require sudden change of direction, continuous acceleration and deceleration, tackling and kicking, just like I'd mentioned in football, due to the functional overuse and repeated microtraumas caused by torsion and traction of the adductor tendon insertions. There are several risk factors that can predispose an athlete to insertional tendinopathy. Decreased hip adduction strength has been shown to be a prevalent risk factor for sustaining a groin injury during athletic participation. Additionally, overloading of the pubic symphysis and insertional tendons can be due to the presence of muscle imbalances, such as weak abdominal muscles responsible for stabilizing the pelvis and strong hypertonic adductor muscles. Secondary intrinsic factors include decreased flexibility of the posterior chain muscles, lumbar hyperlordosis. Extrinsic factors include inappropriate training and proper footwear or poor footwear. Reduced eccentric strength and hip strength deconditioning can explain for a decrease in eccentric hip strength after stopping training, indicating that low-level off-season sport-specific activity is actually a risk factor for groin injuries. During the initial evaluation, a comprehensive postural examination can reveal valuable information by assessing symmetry of the pelvis and posterior superior iliac spines. Clinical palpation can reveal painful points along and near the tendon insertion of the adductors. Manual muscle testing will also reveal adductor weakness and pain with resisted adduction. Passive stretching of the adductors may also elicit pain during the initial evaluation, but it's important to assess the mobility of the hips in all planes, utilizing the Thomas test to reveal shortening of the anterior chain, or utilizing the Patrick or test of Gainsleigh to assess the sacroiliac joint and posterior chain. As previously mentioned, it is important to complete a comprehensive evaluation to rule out other conditions and injuries related to groin pain or that can refer symptoms to the groin. Also, it might be wise to utilize functional testing, such as a single leg stance, a single leg squat, or a star excursion balance test are all valuable functional assessments for hip pathologies. So there are a few goals for phase one of this rehab program, which is again focused on reducing pain and controlling inflammation in the initial symptoms associated with adductor tendinopathy, while initiating a strength training program and restoring range of motion deficits. To protect the damaged tissue, it's important to avoid activities that place a compressive load on the tendon, usually any activities that involve excessive stretching of the affected muscle or direct tendon compression. There are many effective treatment modalities that are frequently utilized for symptom management, such as cryotherapy, moist hot pack when the athlete is no longer in the acute inflammatory phase, oral medication to relieve pain and decrease inflammation with NSAIDs within the acute phase, and as well have been utilized for pain management for short-term relief. Long-term corticosteroid injections in rehab are designed to focus in muscular strength and flexibility and resolving biomechanical abnormalities, also improving lumbopelvic control, core stability, and hip abduction and external rotation strengthening. There should be a combination approach of concentric and eccentric strengthening, muscle endurance, and neuromuscular training, as these are efficient treatment strategies to treat adductor tendinopathy to return the athlete to their pre-injury level of function. Eccentric exercises must be incorporated as it's been effective in improving tendon structure and muscle strength. Some other therapeutic modality options that we can utilize depending on what is available at your clinic or your setting, include ultrasound, extracorporeal shockwave therapy, low-level laser therapy, and cross-fiction massage if necessary. Um, Ultimately, an eccentrically driven rehab protocol is a highly effective treatment for long-standing adductor-related groin pain and beneficial for treating different tendinopathies. Progressive strengthening is essential for professional athletes as there's often lots of pressure to get the athlete back to their sport as quickly as possible. Additionally, eccentric exercise displays superior results in pain reduction, increased strength and function, and return to sport successfully. And it was a crucial modality and intervention for treating longstanding groin pain. So within this first week, I've incorporated cardio warm up with a stationary bike or swimming, aquatics therapy, or pool running, depending on the symptoms the athlete has. Lower extremity stretching is also recommended during muscle repair and a valuable component to incorporate into the rehab program. So focusing on hip flexor, quad, hamstring, gastrocsoleus, IT band, piriformis, and adductors, just a gentle stretch there. During rehabilitation, it's important to address the presence of reduced hip abduction and abdominal muscle strength, which is common in athletes with adductor and pubic related groin pain. It's essential to incorporate core exercises as it leads to an increased ability to control and stabilize the pelvis and hips, increase force production and control in physical activity. So my program is based off the modified Homich et al. Program, which was found to be more effective therapeutic exercise protocol for athletes with long-standing adductor-related groin pain. So again, just like before, starting with some isometrics. Isometrics include a supine ball squeeze, essentially, supine hip adduction, and standing hip adduction, where you're isometrically contracting into a TheraBand or cable column. And also for core, it recommended an isometric boat pose or a V-sit, where you're holding 10-second holds for 3 rounds of 10. An abdominal sit-up, both straight and oblique, were recommended for initiating core strengthening. The same program was continued with progressive hip and core strengthening implemented every other day, with focusing on prone planks and side planks and hip abduction and external rotation strengthening, as well as accessory components for football players, just to ensure they are not losing strength in other areas of the body while they're performing relative rest. On day 4, I incorporated heavy slow resistance, which included standing hip adduction with TheraBand. This was performed this week for 3 rounds of 15 with a 15 rep max resistance strategy with the band, and the tempo being a 3-second concentric phase, 2-second isometric phase, and a 3-second eccentric phase. And then also on day 4 in day 2, implementing eccentric focused hip adduction with standing. So the tempo is a 1-second concentric phase, 2-second isometric, and 3-second eccentric. And this is performed for 5 rounds of 10. So heavy slow resistance with substantial eccentric component can increase the cross-sectional area and density of human tendons and advantageous for protecting and preventing tendon injuries. So during week 2 here, I've incorporated more heavy slow resistance training, but still being performed 2 times a week for the first 2 weeks. And this is now at a 12 rep sequence and with a 12 repetition max weight, with the same tempo being carried out, and as well as submax isometrics and adding eccentric component to the protocol. So the goal of phase 2 is to progress strength, proprioception, and flexibility with gradually increasing the load on the muscle and tendons while continuing to monitor for pain. The clinical goal of this phase is to restore any range of motion deficits that may persist so that passive range of motion is equivalent to the contralateral lower extremity, and increasing the adduction strength to at least 75% of the ipsilateral abductors. And again, continuing to monitor for pain and utilizing modalities as pain management. So during week 3, we've upped the heavy slow resistance to 3 times a week with 3 rounds of 10. Again, 12 rep max as far as our weight load. Heavy slow resistance was found to improve symptoms of tendinopathy and enhance eccentric strengthening. So I've definitely included this in this week's training. I've also implemented progressive core strengthening with like prone planks with alternating arm and leg, side plank with hip abduction, and progressing different types of bridges and hamstring curls, just as different examples. Implementing accessory lifts on days where we are just performing the eccentric component of abduction and abduction. Still that same type of focus as we move through this progression. And then week 4, we implement the new implementation is a Copenhagen adduction exercise, where initially we implement this exercise as it's very, very important and essential to complete and implement into the program once it does not provoke any pain. It can begin with one leg supported on a bench with the other limb on the ground, where we'll progress to the limb isometrically adducting while it remains in the air next to the limb supported on the bench as the athlete's strength progresses. We will also begin with 2 sets of 6 and progressively increase sets and reps as we move forward. So as you can see at the end of the week, we've progressed to 3 sets of 6. So just some different examples here. And then the third phase is to progress the athlete's strength, flexibility, and power development with the main objective to return the athlete to competition. During this phase, we will initiate a running progression. The ultimate clinical goal is to achieve adduction strength that is at least 90 to 100% of the abduction strength, and involved muscle strength is equal to the contralateral uninvolved lower extremity. We'll also be building on phase 2 exercises with progressive resistance, intensity, speed, and volume as well. And again, during this stage, if there's any modalities needed for pain management, feel free to incorporate, and we'll also initiate a running program. So the first day of week 5, we initiated a running program and progressed from day 1 to day 7. And we are just progressing on week 4 exercises and adding progressive lower extremity strengthening. So during this stage, we're going to initiate some lateral lunges, some lateral step-ups, some slide board exercises such as lateral lunges, lateral slides, resisted stride lengths on the cable column, just as some different examples. Well, still progressing our standing hip adduction and abduction eccentric phase focus, and progressive hip core and accessory lifts keep the athlete in shape while they're still potentially performing relative rest from any football competition or being limited with practices. Now, week 6, we are progressing towards a full return to sport progression. So I've broken it down again as day 1 being sport-specific agility drills, day 2, functional strengthening with eccentrics added at the end, and day 3, just plyometric training progressions. And then further on into the week, adding position-specific drills such as blocking, cutting, or running routes, depending on the athlete's position. And then in the middle of the week, we have a relative rest day. Again, I've scheduled a relative rest day instead of a complete rest day because athletes typically experience an increase in pain following complete rest days. So I incorporated some submax isometrics and standing hip adduction with a focus on the eccentric phase. So it's important to continue a preventative postural eccentric strengthening and plyometric exercise program during and after the athlete has returned to sport to maintain an appropriate balance between the posterior chain and the adductor muscles, essentially a good balance between the agonist and antagonist muscle groups. So when the athlete does return to sport, typically we do not want pain to exceed 3 out of 10 on the visual analog scale as a subjective measurement. And then we can either functionally pop test them or provide other functional movement screenings to ensure that no symptoms are provoked with sport-specific training and all power deficits have been restored. And then again, some significant considerations include continuing the eccentric strength program and carrying the same program during the off season to make sure we address all risk factors in the following season, and activity participation resumes once healing is completed. So with adductor tendinopathy, I wanted to kind of implement an injury prevention for adductor strains, as adductor strains are common in sports and can be a chronic injury for some athletes, which results in chronic insertional tendinopathy of the adductor tendons. So adductor strains are also a common risk factor for groin injuries and adductor tendinopathy. So it's important and worthwhile to incorporate an injury prevention program for athletes who are susceptible to sustaining adductor injuries in football. So some suggestions and recommendations that will help achieve the clinical goal of having adduction strength of equivalent to at least 80% of abduction strength include functional warm-ups such as bike, adductor stretching, some sumo squats, lateral lunges, and kneeling pelvic tilts to kind of get the athlete moving. And then incorporating strengthening, some isometric adduction, concentric adduction with resistance against gravity, standing adduction with either a cable or a TheraBand resistance, seated adduction machine just to be incorporated into the strength and conditioning training, slide board lateral sliding with the involved limb, and bilateral adduction on the slide board was also recommended. And performing unilateral lunges was another strength training exercise to incorporate into the strength and conditioning program. Also, utilizing sport-specific training, which can include sport-specific strengthening, change of direction drills, acceleration and deceleration drills, and implementing plyometrics, again, with the clinical goal of adduction strength being at least 80% of abduction strength. Now, this completely concludes my presentation, and here are my references for my presentation on adductor tendinopathy and groin pain in football players. And thank you for your time and attention.